Welcome to Pomegranate Health. I'm Mick Cavazzini and I've just gotten off my e-bike at the Prince of Wales Hospital on Bidjigal and Gadigal lands in Sydney. It's been a long time since I've actually recorded an interview in person, and today's story is going to be a bit different from anything I've done before. I've been invited by a registrar in nuclear medicine, Dr. Karan Singh, to shadow him for the day and share with you some of the interesting medicine and collaborations that he participates in. So let's go find him. Good morning.
I thought I'd be the person that's got a lot of stuff in their hand. How are you?
You've got the weapon already on you. Good morning.
How are you?
Thanks for having me. Great.
Thanks for making all this happen.
It's going to be good.
Come on through.
You're looking remarkably refreshed after 6 weeks. Is it 6 weeks, the baby girl?
7 weeks now.
Congrats.
Things are very slowly.
Dr. Singh is a new father, and he's adapting to this role as he completes his second last year of advanced training. Karan is actually the co-chair for the Trainee Interest Committee of the Australasian Association of Nuclear Medicine Specialists. He reached out with this podcast idea because he felt that the specialty wasn't well appreciated by trainees as they make their career choices. So one Monday in August, I joined him to record this teaser for you.
Nuclear medicine is a relatively small specialty, and I think there's probably not a lot of exposure to medical students, junior medical officers, the undifferentiated registrars. A lot of people have a misconception that nuclear medicine specialists are radiologists, and some and a lot of them are. But certainly you can also access the training pathway through the RACP as an advanced training specialty. And I guess the purpose of me reaching out was to try to increase awareness as to what a nuclear medicine registrar might do, because you often won't see us unless you come to these multidisciplinary team meetings.
I think you said also that it's not a typical rotation in a...
Correct. So it's been, interestingly, there's been a lot of work done behind the scenes advocating for nuclear medicine to be a core rotation during basic training, and so that's been approved. I'm not sure as of today how many trainees get the opportunity to spend time in nuclear medicine.
You told me that you actually started down the paediatrics training pathway. How did you fall into this then?
So I did my basic training and some of my advanced training through the paediatrics route. And then during that time, kind of spent a little bit more time reflecting on the things and the tasks that I enjoyed at work. And that ultimately came down to things like I really enjoyed working through complex cases with colleagues. You know, the highlights of my day would often be when we were sitting having coffee discussing complex diagnostic cases. And so I really enjoyed that cerebral side of things, but at the same time found myself getting quite emotionally fatigued with the lengthy and often complex patient interactions with patients and families. Mm-hmm. And so at the time I did a lot of thinking and spoke to a lot of people and worked through, I think, almost every medical subspecialty I could. And during that time, I visited the Department of Nuclear Medicine at the Children's Hospital at Westmead, and I walked in and everyone just seemed so friendly and happy with their lives.
And relaxed.
Of course, that's not to say they're not working hard, but that was the hook for me to then go in and do my own research. So I spent some time shadowing in the department. I went to one of the nuclear medicine conferences that year, and I was just fascinated by what kind of work day you can have in nuclear medicine, and that was really the hook for me to then apply for nuclear medicine training.
Dr. Singh introduces me to the 4 consultants in his department. The department head and also director of the Specialty Society is Dr. Eva Wegner.
Part of the registrar's work is that he gets constantly interrupted.
Lucky guy.
Quick question, I want to call.
We drop in on Associate Professor Monica Rossley.
She's got so much knowledge. She's the queen of renal nuclear medicine.
Oh, right.
Yeah, worldwide. Mm-hmm. Yes.
At the morning team huddle, we meet Associate Professor Ivan Hirschon, who has interests in oncology and the quantification of PET signals, and Dr. Walter Heindel, who leans towards endocrinology applications.
Hi, how are you? Yeah.
He's just calling me around.
Recruit a few more trainees to the...
Yeah.
That'd be excellent. Yeah.
Also at the meeting are a handful of nurses, a technologist for each of the 5 scanners in the department, and a resident. Nurse practitioner Karen holds court and runs through a list of over a dozen scans scheduled for the day.
Welcome to Monday, everyone. According to the board, I'll just read it through very quickly. We've got the 2 MIGIs, 2 gated venting, 2 gated hub pull scans, 1 I131, one amyloid bone, one straight bone, one next day lympho, which is a breast, and then we've got 11 PETs.
Once the meeting is over, Dr. Singh assists with some patient intakes. With the help of the resident, he educates them about the potential risks of nuclear imaging to ensure their consent. He'll also ask about the patient's history, as there may be factors that can confound interpretation of a scan. Or if the referral contains nothing more than a 2-word request, he'll probe for more information that can help tweak the protocols to maximise sensitivity. The radio tracers are administered in a lead-lined room to contain the radiation that they emit in the form of photons or gamma rays. These emissions are in the next smallest frequency range below X-rays, and there are 2 different ways in which they're captured for imaging. The workhorses of the department are gamma cameras, and these detect photons emitted directly from the decay of a given radioisotope, usually technetium-99m. As long as you're able to pair this to a relevant bioactive ligand, you can image processes in any tissue of interest. Traditional gamma imaging, or scintigraphy, is planar, and on many machines can be captured as a full body scan. Later, we'll get into the advantages of the 3D version of this, called Single Photon Emission Computed Tomography, or SPECT. This isn't to be confused with PET, the other main modality in the NucMed toolkit. Here, the particular radio tracers used emit positrons, and it's only after subatomic collisions in the tissue that gamma rays are generated. While PET technology originally progressed within the domains of translational neurology and cardiology, in the last few decades its use has surged across a range of specialties.
As more is invested into PET, now most departments are split 50-50. And even though it's mostly oncology now, there's a huge focus on infection and inflammation, huge focus on dementia imaging, and a big focus on cardiology as well. And so I guess that brings me to probably the crux of nuclear medicine in its differences from radiology, is that we're focused heavily on what we call emission-based imaging. So the more conventional imaging techniques like CT and X-ray and ultrasound will often use an energy source external to the patient, directed at the patient, and there'll be either a detector on the same side or a different side of the patient that picks up on that signal. Whereas in nuclear medicine, we're injecting the radio tracer or ingesting it or inhaling it, and radiation comes from inside out. That's kind of the crux of the differences.
The simple breakdown, yeah.
I always tell patients, because I've always got a pen on me, and I always tell patients, a CT or X-ray or ultrasound will often be able to tell you the shape of the pen, the size of the pen, but they won't tell you if the pen works. Yeah. Whereas nuclear medicine will tell you, will provide a better assessment of how the pen works.
That's good.
Yeah. How it feels, how it writes, whether it's got ink in it.
That might be the hook to the story.
Dr. Singh, could you please come to scan your phone, please, Dr. Singh?
That's how we get paged in the department. Mm-hmm. So we don't have pages, because I'm not roaming around the hospital, I'm just
very localised. Yeah, you don't have to go too far. Every 20 minutes or so, Karan gets paged to attend one of the imaging suites.
Right?
Yeah, all good.
Hot on his heels. We join technician Amanda in one of the dark control rooms, looking at the chest scans of an 80-year-old man we'll call Eduardo.
Thank you. This is the MIBI study, their resting scan.
Excellent. All right.
The patient has a history of coronary artery disease, and his cardiologist has referred him for myocardial perfusion imaging. Among the team, this gets called a MIBI, after the tracer methoxybutyl isonitrile. The MIBI molecule is lipophilic and cationic, so it sticks to the plasma membrane and then diffuses into the more negatively charged mitochondria. Because myocardial cells have a high concentration of these organelles, they should remain brightly labelled once the tracer has washed out of the circulation. Uneven distribution of the signal under resting conditions may indicate sites of scarring from an old myocardial infarction.
Okay, yep, that looks good.
When you call Karan in, what are you asking him for?
He's just checking to see the quality of the scan, if there's any movement, and also if the heart's able to be seen clearly in all of the the images.
Yeah, so I can't see any of those things that would impede accurate assessment of the heart. And so we'll now move on to the stress component, where we're administering an adenosine infusion to the patient. So adenosine works to vasodilate coronary arteries. And so what we're trying to do here is increase blood flow through those coronary arteries into the left ventricular wall. And if you've got blockages in those arteries where they're unable to dilate as effectively, that'll show up on our scan as areas of relative underperfusion. Partway through that adenosine infusion, we'll inject a higher dose of the same radiopharmaceutical and then make a comparison of the post-stress pictures to the rest pictures. And if there's regions that look different, that might lend itself, that might indicate ischemia. But that's not to say that all blockages in the heart have a functional impact. If that was the case, then this type of test probably wouldn't exist. But we know that sometimes patients have blockages in the heart, but their vessels are still able to dilate. They're still able to provide blood flow to the left ventricle. And so this is a good gatekeeping tool to push referrers in the direction of doing something interventional or optimising their medical management.
Eduardo is already on optimal pharmaceutical management of his coronary artery disease, and his cardiologist will want to know if revascularization is required. Myocardial perfusion imaging is less invasive than coronary angiography and can be particularly helpful in patients who are negative for cardiac biomarkers or red flags on ECG. A nuclear stress test may also be suitable for patients whose physique precludes effective stress echocardiography. Eduardo is removed from the scanner and moved into another room where the stress challenge will be administered.
So this is the part of the test where we'll give you that medicine, adenosine. Now, that will increase the blood flow to your heart and also widen some of the vessels elsewhere in your body. And so you may feel some symptoms when we have the infusion running. So you may get some chest pain, you may get some shortness of breath. Sometimes patients can experience a headache or flushing or some nausea. Those symptoms, once we stop the infusion, should disappear very quickly. So within the first minute after the infusion, they should all be gone.
Little scary.
But we will be monitoring you throughout the test. So you have ECG leads and we'll keep checking your blood pressure, your heart rate, and we will be talking to you throughout. If you feel like it gets too much at any time point, then please let us know and we can stop early as well. All right. Excellent.
Tranquilo. You're in good hands. They will look after you well.
Yeah, I can see. Very nice people.
Just learn the ECG, doctor. There you go.
So throughout the test, could you please move your legs up and down? Are you able to do that?
I hope so.
Yes, perfect. One by one.
There you are.
Just gentle.
I'm very tired, right?
Just take it easy, not too hard, just gentle exercise. Thank you.
As the stress test is completed, Dr. Singh administers the second dose of radiotracer. Eduardo is relieved when he's told he can finally go get some lunch while this infuses. Karan is then called to another room where a bone scan is being conducted.
So I'm not sure, we'll keep jumping around rooms.
This patient is a man of 27 who earlier in the year had a car accident requiring fusion of cervical vertebrae. He's recently been experiencing leg spasms and has been referred by his neurologist to investigate possible causes. For bone scans, the most commonly used tracers are methyl or hydroxy diphosphonate, again bound to the radioisotope technetium-99m. Like normal circulating phosphates, these are absorbed into bone as it mineralizes. A positive signal on this scan likely indicates a sign of bone remodeling.
Excellent. So Mick, here I'm looking at planar imaging of a bone scan. This patient was actually referred for leg spasms, but they've had previous spinal surgery up in the neck.
Wow.
So we'll do focused imaging of both the cervical spine, but also the lower limbs. And so as I'm looking at it, there are no overt sites of significantly increased osteoblastic reaction. So what I'm going to do here now is asked the technologist to perform a SPECT-CT acquisition of the region of interest, and the thing that the team is querying is called heterotopic ossification. That's when you can get bone formation outside of where bone should be, and so we definitely should be able to pick that up on a bone scan.
When Dr. Singh gets to writing up this report, he notes that the targeted SPECT scans show mild radiotracer uptake around the hardware in the patient's neck, but no abnormally intense signal around the pelvis or lower limbs that would explain the patient's pain or spasms. And the X-ray CT images provide no evidence of the heterotopic ossification that was being queried by the referrer. Other pathologic processes that can be associated with a positive bone scan include infection, malignant disease, and rarer conditions like fibrous dysplasia and osteoid osteoma. I'll link to a review that explains how SPECT provides much greater detail and contrast than planar imaging, which can help differentiate suspected skeletal pathology. Hybrid SPECT is even better, given that X-ray CT enables more precise anatomic localization of radiotracer, and also calibration of these signals for tissue density. The limitation of any tomographic imaging, however, has always been the long acquisition times and a restricted field of view that can be captured in one sitting. These constraints are now being overcome with more sensitive and longer bore scanners that allow for fast acquisition of whole body images. This technical advance has contributed to more accurate workups for bone metastases than traditional scintigraphy followed by targeted SPECT CT of equivocal lesions. It also means less need for sedation in restless patients. But let's go back to the floor. As Karan and I are pacing the corridors, he's pulled aside to advise on a bone scan that's been referred with a potentially more sinister indication. The patient is an infant with a fractured femur.
Yeah.
Free to see a bone add-on. It's 7-month-old femur. Showed this.
Oh, yep.
Yeah, no one's seen them.
Yeah.
So I think we're the first of a few scans today.
Oh, yep. For the I might get you to step out for this one, where it's one of the other indications that we do bone scans for often infants and neonates is for screening of non-accidental injury, and so often it's quite a heightened situation in the room, and we can definitely talk about it and include it, but I might not get you to come.
Of course.
So this is at the moment in room 2 we have a child that's been referred for assessment of non-accidental injury, and so the bone scan is a really good whole body assessment of fractures and bone bruising.
And so who would be making that referral?
Typically the general paediatric teams, or sometimes the orthopaedic or neurology teams. Sometimes emergency departments will make that referral, because that's how these children may often first present to an emergency department, whether it be due to a fracture or injury or an unrelated reason and an injury was found at the same time. And often the findings that we see on bone scan will precede findings on X-ray.
I'm thinking a hairline fracture that wouldn't necessarily show up well on a CT would be a hot spot for...
And very occult stress fractures and things like that. A bone scan is exquisitely sensitive at detecting those, particularly in the acute phase. As a nuclear medicine registrar, you may be involved in the assessment of children if your department services the paediatric hospital or the paediatric departments as well, in which case it's important to stay on top of paediatric life support and paediatric sedation requirements, not for all scans, but for some scans and for a certain age range of children. And so it's another interesting thing to stay on top of, so you still maintain your skills in acute medicine and resuscitation and emergency medicine while you're working in a setting that typically is a very outpatient-based specialty. Mm-hmm.
Over the next couple of hours, Dr. Singh flutters from one room to the next to check on more scan acquisitions. One is on a middle-aged woman with suspected gastroparesis. She's been fed radio-labelled pancakes and is undergoing gastric emptying scintigraphy. Then there's an 84-year-old man with recently diagnosed heart failure due to left ventricular hypertrophy. He's been imaged with a delayed amyloid bone scan protocol, shown in recent years to be a very sensitive discriminator for transthyretin cardiac amyloidosis. But not all the patients Karan sees today have come in for diagnostic imaging. One is a 45-year-old man who will receive a radioisotope of iodine to treat a toxic multinodular goiter.
So his thyroid gland has lots of nodules in it, and it's causing him to be in a hyperthyroid state.
Right.
And unfortunately, the medications that are used for hyperthyroidism have some pretty rare but nasty potential side effects, including a significant decrease in your white blood cell count, which can cause severe infections. And so it's often safer, or one of the ways you can treat it is using radioactive iodine therapy, which we help to administer, and as registrars you will help to administer. And that'll destroy some of that hyperactive thyroid tissue, such that you may actually render the patient hypothyroid and they need to take thyroxine, but that's a much safer medication and a much safer route to go down long term than it is to be on high dose medications for hyperthyroidism.
When we go in to see the patient, there is an elaborate dance involved in bringing out the radiopharmaceutical in a small lead-lined vial. The patient is told in great detail how once he's swallowed the pill, he must swiftly exit the building and go straight to his parked car.
You get past High Street. Okay, so you're going to walk out the door, you turn left.
Yep.
You do the zigzag corridor and then you see the long corridor. Keep on walking till daylight, that's High Street.
So I guess for the purposes of explaining things, that radioactive iodine therapy can be administered as low-dose therapy or high-dose therapy. So low-dose therapy is typically administered for benign thyroid disease, so everything but thyroid cancer. And so this patient is getting a dose of 600 megabecquerels of iodine 131. The iodine 131 that we're administering would emit beta rays, which would seek out thyroid cells and cause DNA damage. But a small percentage of the emissions are actually gamma emissions, and the iodine 131 has a half-life that's many days, and so it's important, at least for the first week after they leave hospital, that they practice radiation precautions, and that's mainly to protect other people that don't need the radiation.
Mm-hmm. No public transport?
You're right, it's advisable that they don't sit close to someone for prolonged periods of time for the first few days.
Radioactive iodine is just the tip of the iceberg when it comes to therapeutic nuclear medicine, or what now gets termed theranostics. By tweaking the radioisotopes attached to the tracer molecules, therapeutic doses of radiation can be delivered with incredible precision, and this has had a particular impact in the treatment of neuroendocrine tumours, lymphomas and meningiomas. Dr. Singh describes how theranostics has revolutionised the treatment of prostate cancer.
So what we're doing here is we're imaging prostate-specific membrane antigen, which is highly expressed in aggressive prostate cancers. And so PSMA PET-CT has proven to be another blockbuster application for nuclear medicine. What we're trying to do with gallium-labelled PSMA is we're trying to map where there is a high expression of prostate-specific membrane antigens. It's proven to be excellent and accurate at staging of prostate cancer, restaging in the setting of biochemical recurrence of prostate cancer. And then what we can do with that then is we can swap out the gallium-68 with most commonly lutetium, which is a beta emitter. And it will ideally go to the cells that we've imaged and destroy those cells in the setting of metastatic disease. Okay, so maybe it'd be useful to run through this like I'm reporting a scan.
Yeah, totally.
So here we have a PSMA PET-CT examination of a 64-year-old male with recently diagnosed biopsy-proven prostate cancer, and we're assisting with staging evaluation with a PSMA PET-CT. I can see here as I zone into the prostate, there's abnormal focal intraprostatic PSMA expression within the peripheral zone, within the right peripheral zone posterolaterally at the mid-gland level, in keeping with biopsy-proven prostate cancer. And we're able to quantify that tracer uptake there as well. And of course, as I move up into the remainder of the pelvis, I can see that right here within the pelvis, probably at multiple sites, there are PSMA expressing lymph nodes. And they certainly express PSMA to the extent that would be diagnostic of locoregional nodal metastatic disease. And as I'm moving through the rest of the body, I can see there's a small focus of mild PSMA expression in one of the right-sided ribs laterally. And this is where it's helpful often to look at the underlying CT to understand what morphological abnormalities might exist in that area.
And I'm sure listeners have seen these before, can visualise them, but we've got a CT on the standard CT full body on the left, and then on the right that's been overlaid with this, how would you describe, a more blotchy palette of from green to red.
Correct, and there's no significant abnormalities there, so I'm just going to park that for a second, because I know that on gallium PSMA PET CT, it's not uncommon to have low-grade PSMA expression in bone lesions that are ultimately found to be benign bone lesions. So I'll just park that for the time being. But I can see here in one of the lumbar vertebral bodies, I can see an intense focus of PSMA expression.
Yep, it's a bright red on a background of green.
Correct, and I can see here on the CT there's a sclerotic focus there. So that bone there is more dense than surrounding bone. And so certainly that would make me think of a skeletal metastatic deposit. Of course, there are benign explanations for PSMA expression within bone, one of the main ones being vascular processes like hemangiomas. And so it's important to work through your differential diagnosis, but certainly that degree of uptake with that morphological appearance, that would be very suspicious for a skeletal metastatic deposit.
And then it's up to the oncology team to pursue that if they're...
Correct. If it makes a difference to the management of the patient. And it may make a difference if, for example, after local therapy, they want to institute some external beam radiation to a specific metastatic deposit, or if it's causing pain, that may make a difference. But if they're instituting chemotherapy or something, it may not make a difference. So that's one example of how I would go through a PET CT. And that's also how I would present the PET CT in the urology multidisciplinary team meeting.
Dr. Singh participates in a handful of multidisciplinary discussions every week. This afternoon it's the breast cancer team meeting he needs to prepare for. On the list are 15 patients who have some complexity in their presentation or some turn in their management. There are two main nuclear imaging modalities that contribute to investigations for breast cancer. The first is positron emission tomography, usually paired with the radiotracer FDG, or fluorodeoxyglucose. This radioactive glucose is infused into the circulation, where it's then consumed by energy-hungry cells, as you'd find in rapidly dividing cancers. In other contexts, it can be used to identify active brain regions or sites of inflammation. Karan shows me some scans from a 73-year-old woman with biopsy-proven cancer in the right breast, which shows amplification of the HER2 oncogene. Equivocal findings from a prior ultrasound of axillary lymph nodes prompted a referral for an FDG PET scan to help with staging. Fortunately, there are no signs of tracer uptake in the proximal lymph nodes or beyond, suggesting the cancer is currently localized to the breast. Another useful but non-specific way in which nuclear imaging can contribute to the workup of breast cancer is through a technique known as lymphoscintigraphy.
And the purpose of a lymphoscintigraphy study is to identify the sentinel lymph node that breast might drain to. And the way we do that is by instilling a small amount of radiation around where the tumour is. That gets sucked up by the lymphatic channels within the breast. And we're able to map the first lymph node that drains fluid from around where the tumour is. And if the surgeons can just extract that one lymph node, then send it off to pathologists for a detailed examination, and let's say that's negative and free of cancer, well, then you've saved the patient an operation whereby you're taking out all the lymph nodes within that nodal basin. Historically, they used to take them all out, and that left women often with like swollen arms and lots of side effects. And they found that they didn't need to do that for a lot of women.
So that lymphoscintigraphy is less prognostic than it is guiding the surgeon.
Yes. So the lymph nodes that we identify during our procedure, we're not telling people whether they have cancer in them or not.
Okay, so that, in that sense, that it's not a tracer like FDG that's going into the cancerous cells. It's,
correct.
It's what are you labelling then?
Well, locally we use human serum albumin labelled to technetium, but injecting either subcutaneously or intradermally, utilising the knowledge that that'll get picked up by the lymphatic channels and travel to lymph nodes. And
that drainage, that's not sort of standard anatomy. Like,
that's a good question.
Is the plumbing slightly different in different people, such that
Yes.
you can't predict which node it will be?
Yes, definitely. Because there are so many lymph nodes within the axillary basins.
Right.
Some patients have sentinel lymph nodes that are higher up, some have sentinel lymph nodes that are lower. And sometimes, rarely, you get a sentinel lymph node that's in the other axilla.
Huh.
And so you get drainage or lymphatic drainage from one breast all the way to the contralateral axillary nodal basin. And so really, if you didn't do that procedure and just scraped out some lymph nodes from here, said they were negative, well, you would never know that they drained to the other axilla.
Interesting.
Yeah, so that's where it's... that's the part I find most exciting, when you get an unusual result and you're able to help the referrers, and it's always satisfying to do that. Yeah. For example, recently we performed here at Prince of Wales our first estradiol PET for a patient with suspected metastatic breast cancer who had an FDG PET, and some equivocal findings were noted elsewhere in the body outside of the breast. And upon pathological examination, we came to know that the breast cancer was strongly estrogen receptor positive. And so we performed an estradiol PET to, I guess, troubleshoot those equivocal lesions, and were able to confirm the presence of metastatic disease in those other lesions, and that drastically changed management.
When you said that was one of the first estradiol scans that you'd done, how big a learning curve did that involve?
It is a big learning curve, because you're essentially reviewing, from an imaging standpoint, a different physiologic process. It takes time to familiarise yourself with the physiologic distribution of that tracer. So you can see here that this is an FDG PET CT scan, and the things that pop up the most to the eye on this whole body projection are the kidneys and the bladder.
Which is the normal clearance, by the way.
Correct. And so equally, that then is a bit of a blind spot for FDG
That can
PET.
mask.
Correct. And so there's different tracers have different excretion pathways. So it's important to understand these nuances. So if you get referred patients for, let's say, primary renal cancer, yes, we may be able to make an assessment of staging, but we might not be able to make a local assessment of disease. But I'll often, I guess, going back to the purpose of what I'm doing here, I'm looking through the case to familiarise myself with the pertinent positive findings, pertinent negative findings, and understand if there's any nuances involved that may warrant discussion at today's multidisciplinary tumour board meeting. Because these are specialists that want specialist opinions as well. And so I guess as a registrar, of course, acknowledging the limitations in knowledge that I have, I'll often discuss these scans, particularly the complex ones, with my consultants prior to the meeting. Alternatively, there are some meetings where consultants are present on site to review how I'm presenting scans. And as you become more confident or become more familiar with a particular specialty, that level of supervision might turn from direct supervision to indirect supervision, and so forth.
I go and get myself a banh mi and meet up with Dr. Singh again at the Nellun Comprehensive Cancer Centre. In a small room set up like a theatre, staff from right around the hospital drift in for the meeting. There are medical oncologists and radiation oncologists, surgeons in scrubs, geneticists, about 20 people in all. Karan takes a seat at a computer connected to one of 3 projectors and pulls up the PET scans of the 73-year-old woman that we'd been looking at earlier. Once the meeting starts, the case discussion is led by the patient's breast surgeon.
32 plus, dish not amplified. KCC several is up to 5%. And the biopsy of the lymph node demonstrated fibroadipose tissue with no lymphoid tissue seen. So for that reason, a PET CT scan was recommended.
Thanks, Sam. So this is her FDG PET. This was performed at the beginning of July. As you can see here, that primary in the right breast lower outer quadrant is only mildly metabolically active. Unfortunately, that does limit the sensitivity of our test to screen for metastatic disease. Regardless, moving up towards that right axillary nodal basin, there's nothing that screams out as being involved. Obviously, with that caveat, as stated before. The same goes for distant disease.
We received a right-sided white local excision with a MAC-seed. It shows an invasive ductal carcinoma NST grade 1. We measured as 22 millimeters, so 2.2. There's no
The pathologist takes over with her own slides and a battery of classification scores. Then the other specialists chime in. The patient is not keen on mastectomy. There aren't great chemotherapy options for this type of cancer, though there might be a research study the patient is eligible for. The team converges around whole breast radiation therapy as the best option. As an outsider and a non-clinician, it's humbling for me to watch these experts pool their knowledge to help patients with one of the cruelest hands that nature can deal. There's an earnest but collegiate atmosphere in the room that I can see brings Karan great satisfaction. Over the day, he makes several comments about aspects of his role as registrar that he particularly enjoys, and also how the rapid evolution of the field keeps him enthused about the ever greater impact this specialty will have on diagnosis and prognostication.
I just wanted to let people know that it's a really nice specialty to work in. On-call is relatively less onerous than what it might be for some of the other medical specialties. And so certainly we do on-call, and there are emergencies in nuclear medicine. The main 2 I can think of are performing ventilation perfusion scans for suspected pulmonary embolism, or doing GI bleed studies for suspected gastrointestinal hemorrhage. Outside of those, there are very few emergencies in nuclear medicine, so it's mostly a Monday to Friday kind of 8 to 5, 8 to 6 specialty. You get to work with everyone from neonates all the way to geriatric patients, and work across different specialties as well. And I think it's sitting at the forefront of personalised medicine. Mm-hmm. There is that interaction that you get with patients, and that's inevitably going to increase as theranostics becomes more commonplace within oncology and non-oncology treatment paradigms. And so I'd imagine as that increases, the role of the nuclear medicine specialist is going to turn away from sitting at a computer and reading scans to being a more dynamic part of the MDT, having patient consultations, running clinics. And it's a very cerebral specialty, so it involves a lot of thinking and science and physics and chemistry and IT as well.
And we've already talked a bit about the different traces, the different machines. Do you have to be a bit of a sort of biophysics nerd to enjoy it, or is there enough, medicine,
Yeah. It would be helpful if you're interested in those things. I never did biology and I never did physics at school. Wow. And so for me, it was completely new. And so you will be taught everything that you need to know.
I can see a very faded periodic table of the elements on the wall there. So pop quiz, what's the molecular weight of cerium?
See, I've got no idea. There you go. So if you don't know the molecular weight of cerium, you're still fine to do nuclear. But, in nuclear medicine, we've got access to the whole periodic table, really. Yeah. And so we also work with radiochemists or radiopharmaceutical scientists. And so they're the ones that are focused on producing the radiopharmaceuticals that we use for imaging. And so that's very exciting. Where really, like, some of these agents, or receptors rather, is stuff that we've never seen or done before, and there's untapped potential. And I think we need bright people to enter the specialty. It can be frightening and overwhelming, but with repetition and learning and spending time in the department, all this stuff is very easily and quickly picked up. I'd urge people to look at the core skills that they have and the core skills they'd like to develop when choosing a specialty. As opposed to thinking, I like the science of oncology, so therefore I want to go into oncology.
Yeah.
Because you're not really thinking about the tasks that you're doing on a day-to-day basis.
And they're all going to get boring after a while, or frustrating after a while. So, how can you keep it interesting? And it sounds like nuclear medicine allows the scope. There's a lot of scope for research interests.
Yes. When you're working in a robust department and you've got lots of people that are working to help flow of the department, often the first few hours of the day might be slightly slower than the latter half of the day, because that's the time where patients are being injected or administered with their radioisotope, and then scanning might not commence till a little bit later. And so there's ample opportunity and time to get involved with research, quality improvement within the department, study for things like the basic sciences, bug the technologists about how the physics of all the cameras work. When you start nuclear medicine training, if you're not coming from an imaging background, it is very easy to feel quickly overwhelmed, but that passes, and then you kind of can't imagine life not doing this.
It's a good sell.
Yes. All right, come on, introduce you.
Many thanks to Karan Singh for sharing his passion for this episode of Pomegranate Health. I'm also grateful to his colleagues, and particularly the patients who tolerated having a fly with a microphone on the wall. Dr. Singh encourages anyone who might be curious about nuclear medicine to go and visit their nearest department, or even take up a resident position. A consultant on my review group noted that the case mix will be very different from one department to the next, and there are many interesting applications we haven't even touched on today. He's just one of a handful of college members who kindly volunteered their time to help improve early drafts of this podcast. I've thanked them all by name in the episode notes at the website racp.edu.au/podcast. There you'll also find music credits and a full transcript. For some more explainer on the traces and other technical details you've heard about today, I've embedded links from the StatPearls online textbook, hosted by the National Library of Medicine. Within the College Learning series, you'll find a brief lecture titled Nuclear Medicine Investigations in Pediatrics. I hope today's podcast got you thinking about different career pathways in medicine. Please share it round or leave a review at your favourite pod browsing app. And if you'd like to spend a day in the life in another department or healthcare setting, please email your ideas via the address podcast@racp.edu.au. I'm Mick Cavazzini. Thanks so much for listening.